Hello, how are you all? Hope you all are fine and preparing well for your AMC Part 1 examination. This is Dr. Zahra, and today we will complete our first chapter from Women's Health. And this is a chapter from the John MURTAGHs book, the most important book for AMC Part 1 examination. We are discussing the important lines which can come in exam as single best answer. So let's first do the recap of the uh, previous discussion before moving onward for screening recommendation. Let's do the quick recap. Okay, for first 30 seconds, we will do the quick recap of the previous discussion. So cervical cancer, we all know this is the fourth most common cause of the cancer death, and the most common cervical cancer is squamous cell carcinoma. We discussed in the previous discussion, and cervical cancer almost exclusively occur in women who have been sexually active due to exposure to human papilloma virus. Please remember this. HPV is the most important or the most common risk factor for cervical cancer, and other risk factors: smoking, use of COCP greater than 5 years, immunosuppression, and exposure to diethylestylposterol in uterus. So basic pathology is the transformation zone where columnar cell lining the endocervical canal undergo metaplasia to squamous cell in the region of squamocolumnar junction. So the cells for the samples are focused on the transformation zone. So this is also the important table. Mild dysplasia, always remember as Australian modified Bethesda system, low grade squamous intraepithelial lesion, and sin grade is sin 1. So from moderate onward is high grade. For mild it is low grade, and moderate dysplasia is high grade and sin 2. Severe is also high grade and sin 3, and carcinoma in situ is high grade. Then invasive is invasive. We are labeling as invasive carcinoma. Most common presentation, please remember, most common presentation is postcoital or intermenstrual bleeding, irregular vaginal bleeding, postmenopausal bleeding. Vaginal discharge is also one of the most common complaint, and advanced disease can come as a back pain, fatigue, and vaginal fistula. That's all. Now we will move towards the new section, which is screening recommendation. It is very important as SBA part, because it can come in different questions, and many questions are from this screening recommendation. So please note this point, the very important point. The screening, the cervical screen, the second line, you can read this. The cervical screening test uses a primary HPV test. So they are now using the HPV test to for the screening purpose. So cervical screening, for the cervical screening purpose, for the cervical screening purpose, they are using the HPV test. So for the primary HPV test, they are using the types of HPV as 16, 18, and 12, and other oncogenic HPV type other than 16 and 18. So this is the first screening method for cervical screening test. They are using a primary HPV test for the cervical screening method. All women who have oncogenic HPV types detected. So for suppose the woman is going for the screening test, and screening is coming out positive, like 16, 18, 12, or other oncogenic HPV types are coming as positive, then they are doing the liquid based cytology on the same sample, on the same cervical sample which they have taken for the cervical screening test. If it is coming out HPV positive, then they are doing the liquid based cytology on the cervical sample to guide the further management. So the primary screening method, please don't forget this, the primary screening method is HPV test, and they are using the HPV test for detection of the screening method. And then they, if it is coming out positive, then they are doing the cytology. Who should be screened? This is very important question. Who should be screened? Women are invited to commence cervical screening at 25 years. Okay, so from 25 years onward, women's supposed to go for a cervical screening test. And if the woman is having a sexual intercourse earlier, then they have to go for 2 years. After 2 years, 2 years after first sexual intercourse, whichever is later. So this is the first criteria. Then, second, very important, both HPV vaccinated and non-vaccinated women should be screened. So, even if the woman is HPV vaccinated, if the girl is HPV vaccinated, she should also go for the screening method. And exit test. So, exit test means after that the screening is not required, so should be performed at age 70 to 74 years. All right. And women at age 75 years or older may request a screening. If the woman is 75 year or older, or if she wants to go for the screening, she can request the screening. But exit test is the last test supposed to end at 70 to 74 years. Okay. Screening applies only to asymptomatic women. So, women with postcoital or persistent intermenstrual bleeding require a co-test. So, for suppose if the women, they are giving the question that women having a due for screening test, but they are also mentioning that in the question that women having a complaint of postcoital or persistent intermenstrual bleeding, then in that case it's require a co-test, both HPV test and diagnostic liquid based cytology test. Okay, so in that woman, it's required both test HPV and diagnostic liquid based cytology, and referral for an appropriate investigation to exclude malignancy should be considered. All right. So women who having a these complaint postcoital and persistent intermenstrual bleeding, because this is the most common symptom associated with cervical cancer. So with these two complaints, postcoital or intermenstrual bleeding, they require a co-test, both HPV and diagnostic liquid-based cytology. Next important point, for women who experience first sexual activity at a young age, less than 14 years, and who had not received the HPV vaccine before sexual intercourse, a single HPV test between 20 and 24 years of age could be considered on an individual basis. For suppose if she is girl is having a sexual intercourse and she is less than 14 years and she also had not received the HPV vaccine, then she should undergo this can come as SBA. So she should go under the screening test, a single HPV test between 20 and 24 years of her age, and should be considered. All right. So screening in a particular group, hysterectomy. So what about those women who having a hysterectomy? So it mentioned that cervical screening is still required if the cervix was not completely removed at the time of the hysterectomy. So vaginal wall co-test. So from that women who have undergone for a hysterectomy, then vault co-test. So vaginal vault co-test for HPV and liquid-based cytology both is indicated if there is a history of gynecological dysplasia or malignancy. For suppose if she is going for this, if she has undergone for the hysterectomy due to a malignancy, then both HPV and liquid-based cytology from the vaginal wall is required. Both co-test is required. So co-test means both tests, HPV and liquid-based cytology. Second important point, pregnancy. So cervical screening can be safely performed at any time during pregnancy, but um, um, so correct sampling equipment is used in pregnancy to avoid any associated bleeding which may distress the patient. So in pregnancy we can also perform cervical screening if it is due for postmenopausal women. So postmenopausal women may benefit from a short course of vaginal estrogen before their cervical screening test, provided that treatment should be stopped approximately 3 days before the test to ensure it does not interfere with the test interpretation. So, if the cervical screening test is due in the postmenopausal woman, she can go. We can also provide her vaginal estrogen, but 3 days before the test, it should stop. All right. Immunodeficient women, so women with HIV, this is very important point. Women with HIV, women who are suffering from HIV or who have a solid organ transplant should be screened for every 3 years with HPV testing only. And exposure to diethylestylbesterol in utero, so for suppose if there is a history, then those girls should be test for co-test, and annual and yearly co-test is required, HPV and liquid based cytology, and colposcopic examination of both the cervix and the vagina should be offered indefinitely. Women with abnormal vaginal bleeding, a co-test is indicated and should not be delayed due to the presence of the blood. Okay, women with postcoital bleeding or persistent or unexplained intermenstrual bleeding require referral for colposcopy regardless of the test. So, women who are having this complaint should be referred for colposcopy. But if a single episode of postcoital bleeding and a test are negative, clinically normal cervix and a negative co-test means HPV and liquid-based cytology, both tests are negative, and clinically normal looking cervix, so these women does not need to refer for colposcopy. Only those women who having a persistent postcoital bleeding, unexplained intermenstrual bleeding, and abnormal cervix, and if the test either HPV or liquid-based cytology are positive or abnormal cytology, then those women should be referred for colposcopy. Postmenopausal women with any vaginal bleeding, please, this is very important point. This is very important point. Postmenopausal women is very important to go for to do further investigation to rule out any genital tract malignancy. So any postmenopausal woman should always require a further investigation to rule out the genital tract malignancy.